pause.
Well, we can get started, and as people come on, introduce them. Thanks a lot for having me here today. My name is Michelle Johnston Fleece. I'm a Senior Program Officer at PCORI, which is short for the Patient-Centered Outcomes Research Institute. And I'm here to talk to you today about some of the lessons we've learned at PCORI on engagement, and actually what I have learned personally in my experience working both as a caregiver advocate as well as working in the field now as a professional. And so thank you all for inviting me and joining me here. We can go to the next slide. So I know this is a small group, and I also know it is, at least on the East Coast where I am, a late Friday afternoon. So I do really want this to be discussion based. I will talk to you today again about PCORI, our founding and our approach to engagement. We'll introduce themselves right at the outset. And then again, give you some sense of some of the lessons we've learned and how to get the most out of engagement as a patient partner, but also as teams that are working together. And then I'll go over a bit of our resources that we've developed to support engagement and teams doing engagement, including specifically a little deeper dive on our new tool called Research Fundamentals. I have questions and discussion at the end, but like I said, I'd really like this to be a discussion with you all and welcome you to break in if you have a question or have a comment. I will also pause throughout to also have discussion or open for anyone who wants to ask a question or have a comment. On the online format, it can be a little tricky, so feel free to use the chat or raising hand function or any sorts, or just kind of call out and introduce me. I'll be sort of looking at my slides, looking at the Zoom. So any help, Megan and Linnell, with some of that as well will be appreciated. All right, so next slide, we'll get started with some introductions. And next slide. So I'll just start with giving you a bit more about me. As I said, I'm a senior program officer at PCORI. And in my role here, I'm on our public and patient engagement team. I really focus on what we term the science of engagement, learning about engagement, how it's happening in the projects we fund, what we're learning about that process in terms of what works, but also how it influences the research that we fund and impacts it. So the picture there on the screen, just in terms of my personal history, that young person you see is actually me, the one on the left. That was me and my husband, Matthew, at the Cliffs of Moher in Ireland back in the year 2000. Feels like a lifetime ago. But my journey in the world of healthcare and engagement began with my experience caring for Matthew, who had a rare cancer for about 5 years, and he died in 2004. So when I met Matthew, I was actually working in my first career. I lived in New York and was working in my first career actually in television. And frankly, when he was diagnosed, I left that field because it was very difficult and not feasible to continue working freelance on productions without benefits, but also not knowing when the next job would come, and also working really hard and many hours when I was working. And so I transferred and started working in nonprofits and worked at a community-based organization while he was sick. After he died, I started getting really involved in cancer advocacy work. So did things like Hill visits to Congress, lobbying visits. I actually wrote a column for Cancer Today magazine on caregiving and my experience caregiving, and eventually, served on the board of directors of the National Coalition for Cancer Survivorship, which is a patient advocacy organization. I, at the same time, went and got my master's of public health in graduate school and started working in the field of health policy. Now, at the time, the Affordable Care Act was actually being drafted and then passed a couple of years after I started my work in health policy. And so really it was a time of great change in healthcare. And also kind of the time when we were really shifting to trying to make care more patient-centered and involve patients in healthcare policy decision-making and also at the health system level at hospitals. So I really carved a niche based on my own personal experience and my interests in focusing on patient and family engagement in healthcare. So that's a little about me. The final thing I'll mention is I have a dog and she's very used to walking during this hour. So I've prepared with a bone to keep her busy, but pardon me if she, gets a little barky here and there. So next slide. Want to pause here and just have everyone who's with us to just do a brief introduction. I think we probably have, you can correct me if I'm wrong, I don't know, 10. I'm hoping that we can just go around and have everyone introduce themselves with your name, kind of where you are in the country or the world, and whether or not you've participated as a patient partner on an engagement project in the past. If we can keep it to like a little less than a minute, just because then we'll reserve more time for discussion. So what's the best way to go about this, Linnell? Do you want to?
I can call on people. So
okay, great.
Let's go to Steve first.
My name is Steve Hamburger. I'm located in Westlake Village, California, and I'm a patient advocate for Vascular Cures, and I also do work with American Heart Association through Vascular Cures and another vascular group.
Thanks, Steve. Mishket?
Hello, everyone. This is Mishket Gelouz. I'm living in Dubai. I've been with Vascular Cures since the beginning of the year. After my diagnosis of CLI. And I'm happy to be here with you today, even if it is 1 a.m.
Wow.
He's one of our very dedicated patient partners. Thank you, Mishket, for joining us.
Thank you.
Yeah, thank you.
Jim?
Yeah, good afternoon, middle of the night, early evening for some. Amazing. Thank you for participating from Dubai. Jim Davis, I come through the Vascular Cures connection recently. Had some struggles with ischemia in the leg, still have some wounds on my feet. So very interested in providing whatever help and input I can to this process. Thank you. Oh, and I'm in Southern California now.
Yes.
Jim?
I mean, he's part of our CLTI working group. So thanks, Jim.
You're welcome.
Julie?
Cool. Hi, Julie Thompson. I am in Marin County, north of San Francisco. I am a PAD patient and work, well, actually a patient partner working with the NIH, with the National Heart, Lung, Blood Institute there. Also work with UCSF through Dr. Conti, who is my surgeon there, and also a patient partner through Vascular Cures, working with them on the advisory board, and yeah, as a patient partner. So that's my patient involvement with the organizations. Love doing all of it.
Thanks, Julie. And then we have a call-in number, the 601 number. Would you like to introduce yourself?
Yes, this is Janice. I couldn't get on for some reason, but this is Janice Johnson in Mississippi, and I work with Vascular Cures through patient partners, and I am a well, what I want to say. I'm just glad to be on the meeting. I've been listening to you, to the speaker from the beginning, so interesting. And I'm just glad to be here.
I'm glad you're here too, Janice. And then we can do a quick roundtable of Vascular Cures staff. So I'm Linnell, Director of Programs at Vascular Cures. We have Megan, who's CEO and our fearless leader. Lenny, who is our program associate / technical writer / just a speed demon and can do all sorts of things. And then Lisa, our programs manager extraordinaire. She's also joining. I am calling from Pennsylvania, and Megan, Lenny, and Lisa are all in the San Francisco Bay Area region. Is that correct?
Thank you everyone for joining. We're so grateful to have you. And I'm so grateful to Michelle and the PCORI team for putting this presentation together. And I'm really excited to hear more.
Yeah, you never know these days where people are, right? Calling in from. I am joining you today from a very gray Washington, D.C. And starting to get dark early these days. So, okay, let's move to the next slide. So to set the stage, I'm gonna, again, talk to you a bit about PCORI's origins, sort of how we were created and our approach to engagement, both in terms of what we mean by engagement, but also how we've implemented it in our organization. All right, so to begin, PCORI was established by Congress in 2010 as part of the Affordable Care Act. So PCORI has really been in existence on paper since 2010. And we gave our first funding award in 2012. So when Congress founded or created PCORI, they recognized that despite all the traditional healthcare research available, that patients and those who care for them didn't necessarily have all the information they needed to help guide their healthcare decisions about the choices they faced every day. So we were created to ensure that the research would be more accessible and relevant in order to ease the burden on patients and their physicians in the healthcare decision-making. So we were intentionally called the Patient-Centered Outcomes Research Institute and authorized to conduct research that involves patients and stakeholders to address the questions that are important to them. And so our Board of Governors really translated that mandate for patient-centeredness in some really critical ways and making it part of the criteria for funding from PCORI. So that what that means is the research questions that are being studied and that we fund, those outcomes and the projects must be of importance to patients and those who care for them. And we require that when applicants apply for funding that they demonstrate how it does meet patients' needs. And the studies have to engage or involve patients and stakeholders as partners in the research process. And I'll talk a little bit more about that. One of the other key aspects of our mission is disseminating and promoting the uptake of research findings, because we're, while it's helpful to generate new knowledge and new information, it really can only be effective if people are actually putting it into practice. So that is also another really big emphasis for us. And so from the very beginning, engagement has been fundamental to the structure and purpose of PCORI. Next slide, please. So this is just to help sort of briefly describe the type of research we fund. There are a range of different, kind of research activities across a wide range, all the way from drug discovery and development, all the way through to what we do, which is PCOR, or patient-centered outcomes research. What we call patient-centered outcomes research is really a form of clinical comparative effectiveness research. So bear with me for 1 second as I try to kind of describe these concepts. Comparative clinical effectiveness research, or CER for short, compares the outcomes, and that includes potential benefits as well as potential harms of 2 or more approaches to healthcare. So to kind of make it really simple, drug A versus drug B. If you have 2 different drugs that may treat your condition, our studies would compare those 2. We don't only fund research on particular drugs, but different treatment approaches and various interventions, but they're always comparative. And PCOR, or patient-centered outcomes research, is a type of CER, so it's still comparative research, but it really, as I said before, focuses on the needs, preferences, as well as the outcomes that matter most to patients. And engagement is how we distinguish PCOR, how it's different from traditional healthcare research, but also is the way that it influences our research to be more patient-centered, relevant, and ultimately more useful to be used in practice. Next slide. And so just to kind of dig a little more deeply into these concepts, because they're very related, but distinct in our minds. When we talk about patient-centeredness, we mean that the research, again, like I said, addresses outcomes, both the benefits and harms that are important to patients, that the treatments that are proposed for comparison are currently available. And so what that means is our studies happen in the real world with treatments that are actually available to patients and where they may be having to make real decisions about which course to take in their treatment. And so where there are gaps in knowledge about which treatment is better, that's our sweet spot. And that's where we're conducting research. And also another aspect of patient-centeredness is that the study design and the way the research is conducted is low burden to participants, meaning that the patient's needs and preferences are taken into consideration in the study design to make it actually easier for participants in the study to be part of the study and to stay in the study so that the data collected and the information collected is as complete as possible. And so when I talk about patient and stakeholder engagement, again, what that means is that patients and stakeholders are partners in the research, not just subjects of the research, that we leverage the expertise of patients, clinicians, as well as other stakeholders to improve the way the studies are conducted, and can occur by building upon existing relationships or developing new ones. And I'll talk a bit more about the kind of range of engagement approaches that we see. And then this next slide just gives you a really quick snapshot of our portfolio. In brief, what this slide tells you is we've funded about $3 billion in research since we were founded. The vast majority of that is the clinical comparative effectiveness research that I discussed. And the most studied conditions are, you can see at the top there, mental behavioral health, cancer, cardiovascular diseases, neurological disorders, and then nutritional and metabolic disorders. We also focus intently on funding research that reaches people who have been traditionally underrepresented in research. So you can see on the slide at the bottom right, the number of projects that focus on particular populations of interest. So that includes racial and ethnic minorities, people with low socioeconomic status, women, older adults, and people with multiple chronic conditions. In traditional research, folks in these categories aren't always as well represented in the studies as they could be. Any questions before I get into our approach to engagement within our organization?
I was actually wondering if I could give some vascular specific examples that I think might be helpful.
Absolutely.
And also clarify that the reason that we're here to begin with is we actually received a PCORI award to do the work that is a part of our CLTI working group, which I know many of you are involved in. So even though we're not doing research, we are doing some research, but the objective of that is really to help build the industry's capacity to facilitate patient engagement. We're not actually conducting research studies traditionally as a part of that. And I guess I do want to throw out, so when we talked about patient-centered outcomes, I think the vascular space is has some really great examples of where there is kind of a big difference between the kinds of things that are traditionally measured in clinical trials, such as, does your artery stay open and how open is it? And that's kind of the gold standard that for all clinical trials, but we know and we advocate for other outcome measures such as quality of life. Do your legs still hurt when you walk? Can you move? How mobile are you? I think those all fall in the bucket of things that we would consider to be patient-centered outcomes because they matter more to patients. And so that's why a lot of our work is about advocating for and promoting the use of those outcomes versus others. And of course, connecting with our community to actually tell us what they really believe are important in terms of information is critical to that. So that's all I'll say.
Great. Thanks, Megan. That's helpful.
Yeah.
And I will add, in terms of if you have a question or something pops up, if you want to just put it in the chat, we can go through them, and Michelle can pause and can go through some of the questions if something comes up as we're going through this presentation.
Thanks. Okay, so now I'll just take a few minutes to discuss our approach, PCORI's approach to engagement. And so on this slide, this graphic really shows how patients and stakeholders are foundational to our work, and thus kind of meaningfully involved in the entire process. So you see from the left, from the development of our research priorities all the way through to the dissemination and uptake of findings. So if you go to the next slide, it kind of takes you deeper into exactly what that means, and the scale at which we're doing this. And I show this to help connect the dots on like the actual activities that make up engagement at PCORI at an organizational level, and the scale, as I said. So not only do these activities inform everything we do, they also have helped provide us knowledge and learnings about engagement and how engagement is going. So again, while we didn't invent the approaches or concepts of engagement, what we have uniquely done is engagement on a really grand scale in terms of its breadth, depth, and organizational focus. So for example, we have had 654 awards to organizations and communities, including Vascular Cures, to build research capacity or collaborate and share findings. So those through our engagement awards, which are awards meant to help build capacity in communities and among a wide range of stakeholder groups to build that capacity. We have 427 people who are called PCORI ambassadors. Those are partners, patient partners, as well as other stakeholders who share their experiences with PCORI and engaging in research more broadly in their communities. We've had over 1,000 organizations participate in workshops or convenings to inform our research priorities. And we have actually more than 250 patients and 350 stakeholders who have been involved in our merit review process. So merit review is we have a panel that reviews all of our proposals that come in for funding. Every merit review panel includes a patient and also includes a stakeholder partner along with the other reviewers to ensure that those perspectives are included as we're evaluating a proposal and determining whether or not we will fund it. And we have funded over 600 research projects that themselves involve patients and other stakeholders. So basically what this is showing is that we have a very large laboratory of learning about engagement, while we also produce and fund research that we hope has a big impact in terms of people's health more broadly. Next slide.
Michelle, could you speak to what a stakeholder means for this purpose?
Absolutely. What we call stakeholders are really anyone with an interest in healthcare. And so that is a wide range. We have on our website a list. It's 9 different stakeholder groups. So this is like a pop quiz to see if I'll catch them all on the spot. But when we say patients, that's kind of an umbrella term for brevity for patients, caregivers, as well as advocates and advocacy organizations, clinicians, hospitals and health systems, training institutions. So that means, healthcare research training institutions, industry. So pharma, device manufacturers, policymakers, at the state, local, as well as federal levels who are actually making health policies, payers and purchasers. So that would be insurance companies and employers that provide or purchase health insurance and therefore always making decisions about what they're going to cover, what they're not going to cover. And I lost count on my fingers. That's most of them, but it's on our website and I could provide that afterward. But really it's everybody with a stake in healthcare. And that's a really large group of people. This slide shows you the proportion of the projects we fund and the types of stakeholders with which they engage. So as you can see here on the left, 90% of our projects engage a patient in their work, and 93% engage at least a patient advocacy organization or a caregiver on their project. Also clinicians very well represented at 90%, as often the partner with a patient in making decision makings at that frontline healthcare delivery level. Next slide. And in addition to the ways we engage stakeholders, we've also begun to learn how stakeholders are making an impact on research. So we actually did a study on engagement and how our studies were conducted. And the research team analyzed about 400 examples of how engagement impacted a study. And they did that based on in-depth interviews with 58 PCORI funded projects. So through that work, we found that engagement can impact in the research in many ways, including how a study is designed and planned, how the study activities are actually carried out, the materials related to the study, how they're developed, and what they look like, how study results are shared with others, how researchers and stakeholders actually work together, and how researchers understand the needs of the people and organizations that are affected by their research. So in fact, engagement impacts all aspects of our projects, from the earliest moment in determining the focus of a research study all the way through. Later in the presentation, I'll walk through some of the benefits and challenges of engagement, because there are challenges, and provide like some concrete examples of what it looks like in a project. Next slide. Any questions? I'm going to shift more now into how you and those with whom you might work with or engage with can get the most out of engagement. Okay, just, sorry, window issues. Okay, so next slide. Pardon this graphic, but it is helpful and serves as a basis for some of our thinking about engagement. And I'm going to use it to help talk about the different ways you as a patient partner can engage in work, but also kind of like the big picture. So this shows kind of the continuum of engagement. And by that, I mean, it shows how an individual might get involved in healthcare, both in terms of their level of their involvement, as well as the context in which they engage. And so to explain that, on the very left, the column, are the levels of engagement. So as you go down the column, you see a person may choose to be involved in their direct care, meaning taking an active role in their health and healthcare. That's engagement in healthcare, right? In their own healthcare. The next level down is engagement at the organizational level. So for example, take that one step above that direct encounter with your own healthcare, and potentially, for example, engaging at the hospital or health system where you receive care on a patient advisory council or some other body that's advising on that organizational level. I think kind of research can fit into this bucket as well. And the third level is engaging at a policy level, or involvement on higher level decision making that impact a larger number of patients and others that are served by the healthcare system. This can happen at a local, state, or federal level, policy level as well. So as you move from left to right on this graphic, it kind of lays out the different levels of intensity of engagement. And I'll talk a bit more about this in a future slide, but because we've kind of refined this a little bit with some of our findings. So why don't I just, in the interest of time, move on, and because I'm going to talk about it in basically 2 slides. So this next slide here is kind of moving into the research space. Again, I want to emphasize PCORI, we sit in a specific sort of space in the healthcare landscape, and we obviously focus on research. But why I showed you the last graphic is to really underline that there are many opportunities in health and healthcare to be involved. And it's really based on your kind of interest, your time, and where you really think you want to have an impact. But as we move into kind of the research space, when we were created, there really were no guidelines on how to do this work. And so while we required that projects engage with patients and stakeholders, we didn't tell them how to do it, just that they had to do it. We let them decide how to do it. Realizing that our awardees were looking for some direction, in 2014, we developed what we call the PCORI engagement rubric. And that's what is on this slide, is the content of the engagement rubric. And what the rubric did was to identify a set of principles that should underlie engagement. So those are reciprocal relationships, meaning that these relationships that are developed both sides are getting something out of the relationship. So researchers, but also their partners are receiving benefit from the relationship, co-learning, that everyone is working and learning together, partnerships, as well as transparency, honesty, and trust. And these were laid out in concert with our patient engagement advisory panel. We developed these principles. The other thing the rubric did was provide some really concrete examples around the potential activities and ways they could involve partners throughout the
Quick
research.
question.
Yeah.
Does the rubric go out when there's a request for proposals? Is that included in your kind of bid package, as it were?
Yes.
Awesome.
Yeah,
Very
it's
good.
on our website and it's in all of our applicant materials, but also on the public website and available, you know, for the general public for anyone to use.
Fantastic.
And we've also sort of developed some of our application and the way we monitor projects when they're happening are modeled around some of the aspects of the rubric as well. So it's kind of more influential too in the way we manage the projects and hold projects accountable for doing this work as well. Next slide. Okay, this one is back to the continuum but our kind of updated version based on some of the things we're learning. So again, in addition to sort of choosing your context in which you want to engage, there's also sort of a level or an intensity to engagement. And that can serve the needs of both the entities and organizations that are working with partners, but also the partners themselves. So this slide illustrates and the ways that stakeholders contribute to research, and both in terms of the level of involvement and the decision-making authority that stakeholders have. So as you start on the left and moving to the right, the level and intensity of engagement increases, as does the authority of decision-making that stakeholders hold. So to walk through, on the left is input. So this means stakeholders participating on a study provide opinions to researchers, and often this can mean focus groups or surveys. So it means the information is basically flowing one way to the researchers from patient partners, and there's no broader involvement. As you move to the right, the next is consultation. And that often takes the form of advisory committees or working groups. In this phase in consultation, the researchers may bring aspects of the work for comment and even approval of stakeholders. So you get a bit more of that back and forth and information flow and a bit more decision-making authority. Next step is collaboration. So in collaboration, stakeholders are increasingly involved in co-developing aspects of the study. So this can take the form of a stakeholder or patient co-investigator and a multi-stakeholder steering committee with the power to make decisions on key issues. So again, the sort of level and time effort is increasing, as is the decision-making authority on a particular study. And then finally is shared leadership, which is really true shared power and decision-making, where, for example, there might be a patient co-principal investigator. The principal investigator in research is the head of a project. We do have studies with co-principal investigators that are patients and patient partners. It also could take the form where certain study tasks are led by patients or stakeholders. And I want to note that we present the information horizontally to show there's no hierarchy or value associated with this. There's no correct or better way here necessarily. Most studies actually involve activities at all levels of the continuum. And it really allows some, flexibility to travel along this continuum within a study, and also ensure that engagement is fit for purpose, but also sort of gives stakeholders the ability to choose how their interest and their time allows them to engage with a project. Next slide. So I'll present just some of the findings we have about engagement and how it benefits the various participants in research. So we've learned that engagement benefits the people involved in partnership, but patients, stakeholders, as well as communities. Patients and stakeholders report, among other things, that their experiences with engagement provided them more enthusiasm for research, new professional skills and opportunities, and especially for patients, better management of their own health and healthcare. Communities recognize benefits like building trust, as well as building research capacity within the community. Next slide. Engagement also benefits partner organizations like Vascular Cures, which can include patient advocacy organizations, clinics, health plans, or other community-based organizations that play an essential role in carrying out research. Researchers also describe partner organizations have expanded their missions and began to support new research or look for additional research partnerships. In addition, some partner organizations also benefited financially from project involvement by identifying new funding opportunities. And several partners noted that this funding gave organizations the freedom to work in more innovative ways and to advance their understanding in their communities.
I can personally attest to the fact that patient feedback has actually generated work that we have done, whether it's new programs or actual research studies. So it really happens, really matters.
And then engagement also benefits researchers and their organizations. So researchers report that engagement gives them a deeper understanding of the things they study and inspires a commitment to engagement in the future, whether it's required by their funders or not. Sometimes they go in, okay, it's required, so I'll do it. But we have a lot of converts who would say, I will never not engage again, whether it's required or not. Organizations benefit from establishing and strengthening connections with their communities served by their research, which in turn allows them to more fully understand those communities and carry out research that will be more patient-centered and useful to those communities. And as organizations support individual research teams, they are also building capacity to support and transform the way they do research. And then on the next slide, we talk a bit about the challenges and what we've learned there. So engagement is new to many organizations and to many folks in healthcare, even including patients who haven't traditionally been asked to participate in decision-making about how care is delivered or what research is done. So especially for individuals with less experience, skill, and comfort in engaging, it can feel challenging. So this slide categorizes the types of challenges. So on the left, infrastructure and resources is just what you'd expect. It can be challenging to have readily available trainings and funds and resources to do engagement, including to compensate partners, like pay them for their time. That can challenge research teams. Especially noteworthy is that time challenges everyone. Researchers as well as patients and stakeholders who have complex and busy lives may be dealing with illness, families they are families they are part of, and children they are raising, while balancing that with trying to meaningfully contribute to research. In terms of people and teams, conducting engaged research is a multi-stakeholder enterprise. It involves integrating stakeholders with specific perspectives along with trained researchers who have their own perspectives and interests. So learning about the lived contexts of patients and stakeholders is one of the most important benefits of engagement. But we also have concerns that the people currently participating, while welcome and necessary, often don't represent the diversity of individuals with conditions under study. And so this is an area that is particularly challenging and kind of really a focus of us, but also the field more broadly, and how to better involve the full range and diverse range of people represented in a particular disease area on the research. In terms of organizations, institutional barriers do still remain for researchers. A good example is institutional review boards, which are the boards that really monitor the ethical aspects of research. Sometimes are challenged to see that a patient as a partner on a study is fundamentally different than a participant in a study who's a part of the study as a subject of research, and have sometimes thrown up barriers for involving patient partners, kind of confusing those roles. And so we've been working to help with that. And it's not just patients who have concerns or differing views, sorry, I jumped ahead. PCORI has run also into our own challenges to allow for time and flexibility to maximize the input from engaged partners in our funded projects. So sometimes really valuable and critical input comes up that changes things for a study. And when you're trying to get a study done, sometimes that creates, okay, how do we pivot here and allow for the time and resources to make that change? And then balancing views and priorities is perhaps the greatest challenge. So engagement's not always easy to do. It's also not always easy to live by. So when engaging teams, again, when we have partners and researchers and other stakeholders coming together and offering different perspectives and sometimes different values and conflicts in those priorities and values. So for example, randomized control trials are seen as a gold standard in clinical research, but can be viewed as unjust or unfair by patients and community members. Because in a randomized control trial, you get just sent to one arm of the study or another arm and get different treatments. And sometimes folks are just unwilling or concerned that participating in those projects will mean not all patients have access to new treatments. And it's not just patients who can have concerns or differing views. For example, clinicians don't always agree with this approach either, because they think it can limit their ability to provide the best care to their patients. And so when you come up against these challenges, that can actually be a really complicated challenge to mitigate. So we'll go to the next slide. We're going to pause here and I will be quiet, and we're going to have Julie share a bit about her experience, her own journey and engaging in healthcare.
Yes, so I'm talking as a patient here about my engagement. And I guess a little background. As you hear, grew up in England, moved to San Francisco in 1992. I'm a mother of 3 kids. They're all grown now, but I've always lived a very active lifestyle. Basically started having cramping, I remember, as a teenager in my calves, and then started having very bad swelling in my hands, joints in my 20s, and kept asking different doctors about these conditions. And I never really got an answer. Nobody took me seriously. The cramping in my calves got way, way worse. I could not walk 1 block by the time in my 40s. So basically, one day I remember I was at home and I heard a commercial on TV describing these symptoms. And I quickly wrote down the condition and went to my doctor and said, I think I have claudication. And she said, no way, because I didn't fit any of the profiles for claudication. However, she did take the pulses in my legs, and sure enough, they were very low. And so she referred me on, and basically after several different scans, x-rays, they could see that the arteries in my legs were turning to bone, and therefore there was no blood getting to my calf muscles, and that was causing the cramping. So it was great to have some validation that what I'm feeling wasn't all in my head, and it was something totally bizarre. But I had a very, rare journey from this point. I was sent off to UCSF, where they, were trying to figure out what it was, saw rheumatology, went to genetics, endocrinology, and basically nobody came up with an answer. My genetics doctor was fabulous and said, I go to a lot of conferences and we confer a lot and share stories on patients, and you never know, something might come up. I'll get back to you if I hear. So I was actually recovering from my first surgery when I got a letter from him saying that he had met at a conference somebody with patients, with basically a family of 5 with the same condition as me, and would I be interested in going for a visit to the NIH to be interviewed for their undiagnosed diseases program, which was an amazing new program. It was set up in 2008 for doctors who had patients with diseases that nobody could figure out. And what is great about studying rare diseases, although it seems very remote, it actually can give you a lot of information which help much more common conditions. So basically I went to visit, so engaged as a patient here for a week. So it can take time, but I decided it was probably well worth it. And we were basically diagnosed with their first new disease. So there were, well, at that time, 9 of us. And nobody had ever seen this, and it gave them the information on a new genetic pathway. And everybody was very excited. It was in the New York Times, and Dr. Gall there, it's sort of well spent taxpayers' money. It's been helping with cancer and all sorts of information for different conditions, not just related to vascular disease. But it was great for me. What did I get out of it as a patient? It's great understanding what's going on. So the swelling in my joints was also related to the calcification. Anyway, from that point on, I've been engaged as a patient with the NIH. I visit, it was twice a year. Now I visit once a year, and it's for 2 or 3 days. So appreciate that a lot of people out there might not be able to spare the time, but they look after us very well. I do a lot of tests for them, which helps them. They track how we're all doing, what these new pathways mean. There's lots of different experiments, but they also give me an hour with rheumatology, with lots of different specialists to help me understand. And I get through scans and appointments in 2 days that would probably take me a year, out in the normal field. So that is just really helpful for me and really helpful for them. Also I've worked with UCSF with doctors there and done some tests there. Once again, that's 3 or 4 visits, probably a year. But it's very rewarding to feel that you're helping others and helping advance medicine. So I won't go into all the nitty-gritty, but a lot of it is then those are the more sort of medical partnerships that I have. I'm also engaging with Vascular Cures, which is lots of fun, and we have worked on the website and more about getting out information to the general public about vascular disease, which is huge. There's so many stories of people who have vascular disease that don't know it, and it's so easy to learn about and do something about early on. I mean, because I've always been active and still am, I have managed to avoid a lot of the complications that come with vascular disease. And I think if that information can get out there at early stages, from doctors to patients, or just general information, just like cardiac issues and stroke issues, vascular issues, the information needs to be out there so that people understand the symptoms and what they need to do. I mean, walking is just huge. That is the biggest thing you can do to just, keep yourself healthy. And it doesn't have to be, 2-hour hikes, which I'm still lucky enough to be able to do, even just walking a few blocks a day. So that information definitely needs to get out there. And working with Vascular Cures, that's what we have been doing, working on the website as a patient partner, making all the leaflets much more user-friendly, and basically just trying to help other people. So that makes me feel great. I get something hugely positive out of what could be very negative in my life. And also, learning lots of information from Vascular Cures about vascular disease and the condition. And then also all the contacts that you have. You meet other patients, there's some great support groups out there. Just having contacts at the NIH, contacts at UCSF, my doctor there is amazing, and people that can help you. So if you have the time that you can put in, it's very rewarding. And I totally encourage people to step in and engage.
Thank you, Julie. I am also we've got about 9 or 10 minutes left. So I think we'll just sort of adapt here and ask you all what you most want to focus on. I have some kind of tips and lessons learned here, just that from my own experience and from what we hear from folks. And then I have some slides that show concrete examples of the contributions stakeholders have made to our research projects, but then after that have talk a bit about our tool research fundamentals. And so I think those we could just have discussion here. I think some of those slides you could review kind of after this meeting. You don't necessarily need me. So if just let me know, Megan, Linnell, but also the folks on the call, what sounds best to you in terms of kind of the last sort of bit of time we have together, what can be most useful. I would like to hear from folks, so I want to give that opportunity as well. What we have learned, or again, what I've learned is there are many ways to engage. And I think Julie's story is, illustrative of that. People don't only engage in research, that's our focus at PCORI, but there are many and growing all the time opportunities in all aspects of health and healthcare. And what I really want to leave you with and really want to emphasize is you are an expert. You're an expert in your own body, your own experience, as well as the context of your life, your community, and your living with any condition or circumstances. So it can sometimes feel intimidating to join a group with people with lots of letters behind their name and experiences, researchers, but you have so much to contribute to the process, and you don't need technical expertise in research or the process or biology to make really significant contributions. You may choose as well how to engage based on your interests, skills, time, and desire. And key, that may evolve over time. It may get more involved, it may get less involved based on your interest or ability or just what's going on in life. And that's okay, because there are many opportunities that could match sort of where you are at any given time. One other key thing is that I learned early was it's really important to learn how to use your story and apply it to kind of a broader issue. So beyond your personal experience, but using that experience, but being able to kind of represent, if you will, a broader group of people. And so there are lots of trainings and other opportunities around helping to shape one's story and how they kind of bring it into that context. Because I find the most constructive, and was constructive for me in sharing my story, was providing insights around what it's like actually living with or managing an illness, but where it could be more broadly applied beyond my own personal experience. And then just, again, engagement is new to a lot of researchers and institutions, so it's a work in progress. It may require some patience. It may require providing feedback and advocating for your needs, but it is, like I said, constantly evolving and a work in progress. And then the last I would say is building trust and relationships is critical. We at PCORI try to fund projects to build community and capacity and include enough timeline and in our projects so that those relationships can really be built and strengthened. And that is kind of critical as well to making engagement work. Like anything, it's about relationships and who you're working with. And so tending to those relationships is important. So I just wanted to pause to see if anyone had any thoughts or questions before we wrap up, and I can kind of touch on the research fundamentals.
Actually, more of a compliment. Thank you for bravely sharing your journey, and then also the other story was heartfelt. Thank you.
Thanks, Jim. Well, actually, the patients that are currently on the call have engaged on a certain level with Vascular Cures and in other projects. So I want to open it up for a couple people just to share about their experience, if you're comfortable doing that. Otherwise, we can give a few minutes back to your time, but I do want to provide the opportunity for you to talk about your experience. Steve, you unmuted first.
Well, I'm kind of, I'm a supporter of a natural bypass with regard to peripheral artery disease, which means really rather than, well, I thought it meant really, not having surgery, bypass surgery, and electing to build your collaterals through exercise, medication, and diet. And so I've tried to be a proponent of that, and I've been able to give input and review material and guidance in that particular area. And as I've done that, probably over the last 6 years, I was diagnosed about 14 years ago with peripheral artery disease. I probably had it longer than that, but that's when I was diagnosed and a bypass was suggested. But along the way, I really, till recently, had kind of taken a kind of a strict perspective of, avoiding surgery and taking the natural bypass route. But I actually started a Facebook group about 6 months ago. And as that's grown, I actually was counseled by one of the other patients that kind of said, Steve, you're restricting the group by just making it one or the other. So we've essentially widened the group. And also I've seen in the other Facebook groups, and I've now come to realize that, the approach that I'm taking, which is made up of all of the three things: exercise, diet, and meds, really comes in all phases of peripheral artery disease. In other words, if you've had surgery, and there are many forms of surgery, obviously, you still can improve your physical condition if you subscribe to some form of exercise regimen, dietary changes, including smoking cessation, and exercise. My view is kind of broadened, the more I've gotten involved in terms of, how what I've done can apply.
Thank you so much, Steve. That's really well said.
Yeah.
Well, we are at 4:59. We're at time. So thank you everyone for joining. Huge thanks to you, Michelle. Again, thank you it was such an informative discussion. I learned a lot from it as well.
Yeah, and I will share the slides. They have links particularly to our resources, and there's information there about Research Fundamentals, which is our online training tool for anybody who's interested in learning more about research. That's just there to help people that are new to research understand more about how research works. So that's pretty self-explanatory, I think, in the slides, and you can also, has the URL, you can visit it. But I'm also available for any follow-up questions, or if you have any thoughts after we hang up, feel free to reach out. Megan and Linnell definitely know how to reach me. I think in my slides, I have my email. So you could just also email me directly if you like. It was a pleasure to be here today. And thanks to those of you who joined from all over the world and at all hours of the day and night.
Thank you, everyone.
Zoom.
This was fun. Thank you so much, Michelle.
Yeah, thank you, everybody.
Have a good weekend.